Good evening, all. A very warm welcome to this cataract update on multifocal intraocular lenses, the science of vision born from the needs of daily life. Our chair for today is none other than Dr. Prema Padmanabhan. Her name is synonymous with excellence and innovation in cataract, cornea, and refractive surgery and research. So, our chair for today is none other than Dr. Prema Padmanabhan. Her name is synonymous with excellence and innovation in cataract, cornea, and refractive surgery and research. She has delivered numerous prestigious orations, including Noel Memorial Oration, Professor Palikaris,
Okay.
and many others. Her research has earned multiple Best Paper awards and medals. She has also been recognized with the ISCKRS Excellence Award for Outstanding Achievements in Cornea, the T. Agarwal Gold Medal, and most recently the AIOS G.N. Rao Endowment Lecture, where she delivered a visionary talk titled The Wheels of Vision. It is an honor to have her lead this webinar as the chair. We have an impeccable panel comprising of accomplished cataract surgeons, each of whom brings exceptional surgical skill and clinical acumen. I welcome our panelists, Dr. Sudhir, Dr. Sudarshan, Dr. Amala Elizabeth George, Dr. Kavita Kalaivani, and Dr. Rajesh. It is my honor to welcome Dr. Savio Pereira, a highly respected senior consultant at Netradama Super Specialty Eye Hospital, Bengaluru. With over 11 years of dedicated service, Dr. Pereira is a leading expert in managing complex cataract cases and performing a wide range of advanced refractive surgeries. Dr. Pereira has played an active role in numerous international clinical trials involving intraocular lenses, state of the art refractive laser platforms, and advanced phacoemulsification technologies. Beyond his clinical excellence, Dr. Pereira is also a passionate educator, serving as fellowship director for the phaco refractive program, DNB coordinator, and a DNB examiner as well. He is also a certified trainer for ZEISS refractive courses, including SMILE and many others. He has significantly contributed to the advancement of cataract and refractive surgery, both in India and internationally. Please join me welcoming Dr. Pereira to give his talk on overview of multifocal IOL designs. Over to you, Dr. Savio.
First of all, thank you very much. I want to thank Shankar Netralaya for giving me this opportunity. And I'll be talking about the overview of multifocal IOL designs. So this is something very unique. And any presentation that we start, we should give credit to our history. And that is nothing but Sir Harold Ridley, who put the first IOL. And this talk would not have been happening if this was not a part of the entire experiment which he did and gave so many patients. So this is the photo of the first lens that was implanted. Now, in the early 80s and the late 70s, there was one surgeon who put a lens, which was a monofocal lens, in a high myopic patient, and it subluxated superiorly. He was worried what would happen. But the next day, the patient was very happy because the patient could see distance from the top part of the lens or the pupil, and from the aphakic part, the patient could read, being myopic. And this gave the entire concept that you can have multiple foci of light in the eye and still be able to read. So this is what was the earlier designs of the lens, which was the bullseye, which was a refractive lens where you could see for near distance, and there were different refractive zones which were there. Now, to give you the idea, which was the first generation, you can see you have the near focus and you have the far focus. But there is a lot of stray light which is over here all around. And this is causing the difference of multiple glare halos that you experiment. So if you look closely, this is how a person would see with a monofocal lens, but a multifocal lens, the earlier designs, this is how a person would see. And you can see there's this ghosting of images round each and every alphabet. So this was something which was not very good. Now, to understand this, we need to understand that each and every patient will have glare halos and reduced contrast sensitivity once you have multiple foci of light. And this is because it's a very simple thing. If you hold your thumb in front of your hand and you look at something far, the thumb blurs out. At the same way, when you look at your thumb in front, the background image blurs out. And this is because there are two foci at all point in time, but the brain chooses what it wants to see. And whenever you have multiple foci, you will have reduced light, especially if the light is split. So there was something coming. Why don't we go ahead and do like a distance and a near, a sectoral lens? And this was very popular in the earlier days where the near vision was focused by the lower part, but the distant vision was focused in the upper part of the lens, very similar to the bifocal lenses that we have in our glasses. But it also had problems, which I will be telling you later on. Then came the diffractive lenses. We all know about the constructive interference and the destructive interference of light. And if you have lenses with multiple rings on them, you will see that light gets split. So, depending on the number of rings and depending on the height and the width, you could play around with the optics. So, if you have lenses of larger width of the rings, then the light gets split up and you can have different addition powers. To give you an example, earlier days you would get multifocal or bifocal lenses of plus 3.25, plus 3. You could put one in the eye for distance, for near, another one for distant and intermediate. And this was a mix and match, which was nothing but playing with the diffractive steps. Also, you could have diffractive lenses of different height. If you have the ring of a much larger height or a much smaller height, you could play around with the energy. And if you had a larger height, you could put more light for near. And if you had a smaller height, more light for distance. So then came, why don't we do something called as apodization, where you gradually decrease each and every step of light as you keep on going from the center to the periphery. And this is something which is used. But the thing is, if you go from point A to point B and you have shallower steps, you need more number of rings. And if you look at this, this is the photo of the Zeiss 80 Lisa 839. This has rings up to the periphery. So you need to make a large rexis because you need more light to enter into the eye. Coming to the point of glare, halos, starburst, we have to understand that this is nothing but a compromise that patients do have to make. So when we had the refractive lenses, the diffractive lenses, why not have the best of both worlds? And then came the combined lenses or the hybrid, where you had diffractive and refractive zones. Now, whenever you do that, you should understand that light is split, and when light is split, you are losing light energy. That is why patients with multifocal, trifocals, they need more light. This is an idea of each and every type of lens that is there, of the trifocals, which are commonly used, and how much percentage of light is actually made available. So this is the split of light. You should remember that if you're putting, say, an 80 Lisa, if it's far, 40% light there, is only 85% of 40% is actually made available. So this is something which we should keep in mind, especially in patients who have ARMD, glaucoma, who already have a relative lesser sensitive retina. You're going to have more light coming in, which is going to be dispersed and cause more problems. So coming back to the hybrid design, what this design does is when you have the diffractive zones in the center, in the night, when the pupil dilates, the refractive zones come into play and allows more light to come in. So you have something like the geometric and the geometric plus, where the geometric plus distributes more light for near. Here you can see the central 3.2 mm zone has only the diffractive zones, while the remaining peripheral is all the refractive optics. This allows about 90% and more amount of light to transmit. And if you put a geometric plus in one eye and a geometric in the other eye, you get more amount of light, which is available when you see binocularly. So coming back, what happened to the bifocal lens, which I was talking earlier? A similar lens came out, which is known as the Femtis lens or the Lentis lens. There are different other lenses, which basically say that there is no loss of light. There's no contrast loss because there are no rings. But it is nothing but a progressive glass. And these lenses were fixed to the central capsule, or you required a femto lens to put a flak surgery to put the Femtis lens. But then you had patients complaining of angel wing glare. And if you look closely at your progressive glasses, this is the zone where the patient doesn't see. If you have a wide corridor, this is reduced, but the similar glare patients were complaining at the edge. And this is very close related to the design of the lens. If you go back, and the Bosch and Lobb introduced the Krista lens, which was an accommodative lens, and actually it was a lens which was supposed to cause a little bit about a pseudo accommodation which was occurring. But if you actually see the design of the lens, it had a spherical zone in the center, and which was one of the earlier EDOF lenses, but it was not told to the people. But actually, it was the spherical zone in the center which was helping people to see. Why am I talking about this? This is where EDOF technology comes in. And nothing but it's stretching light, where it gives you a little bit more depth of field, depth of focus. And you have different generations where you had a small aperture, diffractive lenses, or introducing spherical aberrations in the center, like how the Pure C does. On now you have the wavefront and something more like the Galaxy Rayner lenses, which has multiple spiral zones. But at the end of the day, remember, whenever you're putting these EDOF lenses, you are actually shaping light. So patient does have a halo, and it does require some neuro adaptation. Coming to the newer lenses, which you have the fluid lenses and the new lenses, if you look and see, we are going back to Harold Ridley's design of a perfect lens, which is round. And these lenses have a fluid in the center and which is pushed to the periphery as the person accommodates. It's basically based a little bit on the ciliary spasm, which causes changes in the capsular bag. But still, these are in study phase and they are not very well, I would say, acceptable, and they still which need more evaluation. Coming back, I would say whenever you get a patient, it always comes to giving them the option of spectacle independence when a patient comes to you. And be it a toric lens, an EDOF lens, a multifocal or a trifocal, you need to see what are their needs, what are the questions they are, their hobbies, their daily routine, and we need to address each and every patient. Some of them have undergone refractive surgery, some of them already want to get rid of glasses, and we need to understand what is their exact need. Some of them may already have a multifocal lens in one eye, or may have a monofocal and desire to be glasses free, and that's the time where we have to do a mix and match to try to get a continuous range of vision without affecting the contrast, color, and also the difference in images between the two eyes. Regarding torics, be very careful, especially you have all the multifocal trifocals in toric designs also. You need to reduce the cylinder to less than zero point 0.5 so that you get the maximum benefit. This is just a case to show you that if you get the holiday AKR reading and you see a diffuse mountain over here, that means this patient is not good for a toric lens. While if a patient has a good peak of the mountain, it's very easy and the patient will benefit from a toric lens. Coming to the contraindications, I would say these are regular contraindications that we need to keep. Anything which will displace the lens or cause the lens to shift with time, we need to be careful. This is something I need to touch on is the angle alpha and the angle kappa. Angle kappa is useful for your refractive surgeries because the laser and the tracker works on the pupil. It's a pupil tracker. While angle alpha is the center of the nodal point where the eye, where the bag is, where we need to see that is less than 0.5, especially when you're putting your multifocal, trifocal lenses. Just coming to the spherical aberrations, you should understand that it's the corneal aberrations that matter. The internal anyway will change once you do the surgery. So that's not going to really affect you. If you have very large axial length eyes, be careful because your biometry tends to go for a toss. And also your formulas, you need to adjust that. And that is also the problem when you have very short eyes or hyperopic eyes, the ELP changes. So be a little careful about that. This is just one of the cases I would like to show. Biometry in a very high axial length eye. If you don't put the laser vision correction as untreated, the patient has undergone LASIK, just see the change in the IOL power. Here you're showing a 0 and here you're showing 2.5. So the more the axial length, the more the chance of you being off. So be a little careful. Also, coming to the summary, I would just say you need to counsel your patients for glasses independence. Always have realistic expectations. Understanding IOL design helps you to give the better to your patient what they need, what is the customized, tailor-made needs of your patient. Remember, all of them decrease contrast, glare, and halos. You have to have a fine balance between all of them. Always under promise and over deliver in your complicated cases. Update yourself about newer technologies and always remember history repeats itself. We're going back again to the Harold Ridley's design. I showed you all how the bifocal lenses are coming back and how different lenses come. So there is a variety of choices which are there. But at the end of the day, we should always see what our patient needs and address that and give it the best outcome to your patient. Thank you very much. And thank you for giving this opportunity. I'll be taking questions at the end. Thank you so much.
Thank you so much for the wonderful and comprehensive talk. Right now, we'll have the next talk for this webinar, which would be by our esteemed consultant, Dr. Harsha Nayak. So, it is my pleasure to introduce a dynamic and forward thinking professional, Dr. Harsha Nayak, and he is currently serving as the Medical Affairs Manager at Alcon Laboratories, India. And he brings a unique and powerful combination of expertise in medical marketing, regulatory affairs, academic training, and clinical research. His background spans across preclinical and clinical drug development, including clinical trials, pharmacovigilance, and regulatory processes, making him an invaluable asset. With an innate flair for project marketing and deep understanding of drug therapy, he bridges the gap between science and strategy with precision and clarity. His skill set is especially suited to roles that require representing the organization as a medical expert and a clinical pharmacologist. It is my honor to welcome Dr. Nayak to talk upon the comparative clinical outcomes, what the studies show. Over to you, Dr. Nayak.
I think that was a good presentation from Dr. Savio. He has covered most of the design aspect. But however, I would like to discuss only on, I will be focusing mainly on these two IOLs, multifocal IOLs. So one is the Panoptics and the other one is Synergy IOL. So before we go into that, as we all know that, so modern cataract patients, they have a very high demand, so they want to be spectacle free once they have been implanted with the IOL. And also most of these patients, they are used to these recent available electronic gadgets. So that is one thing, I think, which is quite challenging when it comes to addressing these issues. So there are various options that are available in the market in terms of IOL with various designs, which Dr. Xavier told in his last presentation. So I'll be focusing on Panoptics and Synergy. So before we go into the study per se, so let us see design wise what exactly is the difference between these two IOLs. So Panoptics, it's a Acrysoft hydrophobic acrylic material IOL, and if you could see this picture over here, so you can see that it has got an aspheric anterior diffractive surface, but the posterior surface is spherical. Now it has got those multiple rings which can be seen on the anterior surface of this IOL, and the 4.5 central diffractive zone. Beyond that also you can see a zone. So overall, if you take the overall diameter of this IOL would come up to 6 that can be used as a optical diameter. Now it comes with the Enlighten optical technology. So here what happens, once the rays of light which passes through this IOL, what happens, there will be redistribution of the light from the intermediate focal point to the distance and also to further. So there is enhanced utilization of light energy here. So what Dr. Savio presented in his presentation, you would have seen that 88%, it allows the 88% of the light to pass through it, and out of that 50% is allocated for the distant vision, and 25% for intermediate, and 25% to near. So apart from that, if you see the defocus curve of this IOL, it provides the visual acuity of up to 2016 for distance. When it comes to intermediate and the near vision, so most of these patients, they fall under 2020 or 2025. So that's the vision they will be having in terms of intermediate and near vision. Now if you go to the Synergy, so the design is a little different as compared to the Panoptics. So in the Panoptics, we saw that on the anterior surface there was a diffractive zone, or the rings, what we these concentric rings, whereas here it's the other way around. So here the posterior, you have this diffractive surface. So the concentric rings what you're seeing here, they are seen on the posterior part of the this IOL as compared to panoptics, which is seen on the anterior surface. Again, this is again made up of the same material that of panoptics, hydrophobic acrylic material, but this is an UV light absorbing material and a violet light filtering chromophobe. Whereas panoptics, if you see, it's a blue light filtering chromophobe. It has got that. So these are the few technical changes that are seen grossly if you see the design wise. Now let me see clinically, do we have find any difference in the visual acuity or the spectacle independence or in terms of the visual disturbance profile? Now, this is a head-on head comparison study. So basically, it's a non-inferiority study that was done. So prospective multicenter randomized study. So there was bilateral implantation of either of these two IOLs, Panoptics or Synergy, and the patients were followed up for a period of up to 6 months after surgery. Now, the key outcomes they wanted to look was in terms of visual acuity, that is photopic distance corrected visual acuity. Then you have photopic defocus curve. Then we also have spectacle independence or the spectacle usage, which was assessed by using the IOL SAT questionnaire. Then we had the binocular mesopic distance corrected, or the both in photopic and mesopic conditions, they wanted to see the visual acuity. Now, safety wise, they wanted to check for the visual disturbance profile, which IOL, which group of patients they had the better tolerability of these IOLs, because since they come up with the diffractive technology, so they bound to have some amount of visual disturbance. So if you see the patient disposition here, it was a 1:1 randomization, and the patient were randomized into two different groups. One group received Panoptics and the other received Synergy. So they were followed up. The follow-up visits were at post-surgery after 1 month, then 3 months, and then 6 months. So the overall patients that were available for the analysis were 138 in each of these groups. Now coming to the key inclusion criteria, so both the adults who have been diagnosed with bilaterally age-related cataract, and they have been planned for cataract removal either with femtolaser assisted cataract surgery, or they can be done by using the phacoemulsification as well. Now, the projected best corrected distant visual acuity at the time of when the patients were recruited in the study should be 0.1 logmar or better, and the preoperative regular keratometric astigmatism of less than or equal to 0.75 diopter in both the eyes. And the key inclusion criteria is generally what we see in most of the clinical trials, like they shouldn't have got any other ocular surface or surface diseases or any corneal abnormality or any degenerative diseases, any ocular pathology that is going to affect the post-operative best corrected distant visual acuity, and etc. So if you see the demographic profile here, both these groups, they were comparable to each other. So there was no statistically or any clinically relevant differences that was seen between these two groups. Coming to the visual outcome and refractive, the post-operative refractive outcomes, if you see here, so both the IOLs, they do very good in terms of providing the refractive outcomes. So there is no any difference between these two IOLs when it comes to the post-op refractive outcomes. In terms of photopic visual acuity at 6 months, again you see they both of them are they are comparable to each other. There is no difference. They do provide, both of them, they provide a good distant corrected visual acuity as well as the uncorrected visual acuity. However, the maximum difference in the mean binocular visual acuity was seen between these two IOLs was of 1.5 letters, which was not clinically significant as well. Okay. Now coming to the percentage of subjects with binocular photopic visual acuity at whoever had 20/20 or better visual acuity. So in both the groups, you can see numerically, I think few patients they had better outcomes in panoptics as compared to synergy, but statistically it is not significant. So we consider that both these IOLs, they do very good in terms of photopic visual acuities. Now coming to the binocular mesopic visual acuity at 6 months, again both are the panoptics was non-inferior to synergy, and the maximum difference that was seen was in terms of mesopic visual acuity was 2 letters as compared to the photopic, which was 1.5 letters between these two IOLs. However, it was not clinically significant. Now, so whatever result we saw over there, the same thing is reflecting here in terms of the defocus curve. They almost overlap with each other. Both of them, they're providing a good visual acuity in the range of 2025 to 2032. Uh, so coming to the spectacle independence, so both of them, both the IOLs, they provide a high level of spectacle independence. So any patients who have been implanted with either of these IOLs, so they have a very good level of spectacle independence. So this is again the IOL SAT questionnaire through which they assess. So if you see this below never, the percentage of never is quite high, either in bright light conditions or even in the dim light conditions for both these IOLs. Now, in terms of contrast sensitivity, also we know that they are known to reduce the contrast sensitivity because of their technology, what they bring, what they have. So these two again, they do have a similar kind of contrast sensitivity after 3 months of surgery. Now, coming to the last part, the safety one, the patient reported visual acuity phenomena. Now, this is where there is some disturbance. You could, I mean, some difference that you could see between these two IOLs. So, compared to synergy, so those patients who were implanted with the panoptics were able to tolerate the adverse events or the visual disturbances like starburst and glare was better tolerated with panoptics as compared to synergy, and this appears to be statistically significant. So this is one key difference that was seen in this study in terms of visual disturbance profile. And again, most of these synergy implanted subjects, they reported moderate to severe starburst as well as glare as compared to the panoptics group. Similarly, in terms of bothersome of visual disturbance, you see the numbers were quite high with the synergy group as compared to the panoptics group. So overall, if you take the patient satisfaction, again, most of them, they were happy with the IOL what they have. But if given a choice, or would they like to have a similar lens again, or they would recommend any of their family friends or not? So the percentage was little higher with the panoptics as compared to synergy. And in terms of overall, to summarize, so both these IOLs, they come with an diffractive technology, and both of them, they tend to provide a very good visual acuity in terms of either in mesopic or even in photopic conditions. Both these IOLs provide a very good high spectacle independence, and even the patient satisfaction is quite good between these two IOLs. However, the only difference that could be seen between these two IOLs is the visual disturbance profile, which is better tolerated with the panoptics in terms of starbursts and glare as compared to synergy. Uh, Thank you.
Thank you so much, sir, for the very enriching talk. Up next is the much awaited talk by Dr. D. Ramamurthy on case based experience Pearls from Practice. It is my pleasure to welcome Dr. D. Ramamurthy, a distinguished leader in the field of ophthalmology. He is currently the chairman of the Eye Foundation, a chain of advanced eye hospitals across South India. His clinical expertise lies in cutting edge cataract and refractive surgery techniques. Dr. Ramamurthy has made significant contributions to the ophthalmic community, having served as the chairman of scientific committee and later as the president of AIOS. He has delivered 26 named orations in India and abroad and is a sought after speaker and surgeon, having performed live surgeries globally. With 67 publications in peer reviewed journals, his academic contributions are equally impressive. Please join me in warmly welcoming Dr. D. Ramamurthy. Over to you, sir.
Thank you so much for that very nice introduction. And thank you, Shika, for this kind invitation and a wonderful opportunity to once again interact with the distinguished colleagues at Shankar Nethralaya. Truly appreciate this great occasion. The topic given to me is slightly different in the sense that it's a practical overview of a case-based experience, pearls from practice. As far as financial disclosure is concerned, since Johnson and Johnson asked me to speak on this occasion, most of my slides are leading to slides from that platform. But then we do widely use all the other platforms that have been talked about, and we do appreciate that it's the quality of these lenses that matter the most. Oh, this is the first case I'm going to be presenting to you about, which is what we do in 95% of the situation where we implant, and most of my lenses are about advanced technology intraocular lenses, that is either multifocals, trifocals, continuous range of vision lenses, or toric intraocular lenses. And where we implant similar type of intraocular lenses, like in this simple straightforward case, which doesn't have much of a cylinder, requiring a plus 21.5 and a plus 22 diopter intraocular lens. Bilaterally, we implant a continuous range of vision intraocular lens. And as most of us are used to, we get a excellent visual, good quality visual outcome of 6 by 6 and 6 and intermediate vision also 2020. You can achieve with various other platforms that are available to us today. And at least in my practice, 95% of the eyes fall in this scenario, where we implant similar kind of intraocular lenses in both eyes, and the patients by and large are their requirements are quite met with this choice. But then we come to different scenarios where we have to exercise a caution as well as our ability to mix and match lenses. POC is an intraocular lens which has come into the market recently. We are involved in a global study also, and we have used about 56 lenses so far. And one of the premium features of this lens is a excellent quality distant vision, intermediate vision quality that it gives. But as far as near vision is concerned, it's somewhat inadequate. And most often what we find is it gives an innate visual acuity for uncorrected near visual acuity, and requires about a plus 0.5 or a plus 0.75, a little less than what was required with the Symphony for a clear near vision. And this is what this patient experienced as far as the left eye surgery was concerned. Usually, I allow a period of about 1 to 2 weeks between the two eye surgery, not only because of to ensure that the first eye is done well. Oftentimes, I believe that we learn a lot as to what to implant in the second eye from the outcome in the first eye. Patient was obviously seeking a somewhat better visual acuity as far as near vision is concerned, uncorrected near visual acuity. So the patient required a plus 21.5 in the right eye, which was operated upon a week later. But here we chose a simple micromonovision where we implanted a plus 22 diopter lens. And so bilaterally implanted, what we experience is relative spectacle independence, because for distance, intermediate and near, the patient's requirements are taken care of. And as you can see over here, because of the extended depth of focus that these patients have, and having a relatively longer sweet spot as far as distant visual acuity is concerned, even though we implanted a lens which had a plus 0.5 diopter higher power, the patient has a 6.6 uncorrected visual acuity for all distances. So this is a very simple mix and match that all of us can do without changing the type of lens, but playing around with just the power of the lens, depending upon the visual outcome in the first eye, spectacle independence that is achieved for distance, near, or intermediate. Looking at a different scenario, a 55-year-old male who had a significant conversation as regards the quality of vision as well as spectacle independence. Because I felt that he was more focused on the quality of vision, did a significant amount of night vision, night driving also, I decided to go ahead and implant a eye hands in his first eye. This was again a straightforward walk in the park case where just a spherical error. And once the eye hands was implanted, which as all of us know is essentially a monofocal plus lens, not an EDOF lens. And many of these patients require about plus 1.5, 1.75 diopters for clear near vision. But this patient fortunately required just about a plus 1 diopter for near vision, with emmetropic outcome as far as distant visual acuity was concerned. His intermediate vision was also satisfactory, but obviously he was not quite satisfied with the visual outcome as far as the near vision was concerned. So he essentially wanted something to be done for which he had already had spoken about. So we decided to together go ahead and implant a synergy in the fellow eye. Obviously, he did not want any compromise as far as quality of vision is concerned. So we did explain to him that it was less than optimal to implant two different technologies in the two eyes. But since visual requirements were required this, we adopted this approach. So once we implanted a synergy in the second eye with a eye hands in the first eye, you can see that the requirement of the near vision an additional power for near vision went away. So bilaterally implanted, this patient did well. So sometimes, apart from playing around with the power of the lens, also playing around with the type of lens that you implant, a monofocal plus lens in one eye, an extended range of lens in the other eye, obviously takes care of the visual requirements of this particular patient. So I do not shy away from mixing and matching even the types of lenses. Then you come to the concept of toric lenses, and I believe very strongly now that whenever you come across a significant cylinder and you're implanting a trifocal or a multifocal intraocular lens, it's extremely important to take care of the cylinder that is there, especially if it's against the rule astigmatism. Here you can see something like a oblique astigmatism, almost of a similar extent in both eyes of the same patient. This patient ended up getting by a colleague of mine, of my own hospital, synergy, not a synergy toric in the left eye. And you can see what he had was a 6/9 uncorrected visual acuity and required as 0.75 diopters of astigmatism correction in his spectacles for his clear distant visual acuity. So not a very satisfied patient as far as the visual acuity for distance is concerned. So essentially what we did was to go ahead and implant in the second eye what we should have done in this first eye also, where we did a LRCS with a synergy toric intraocular lens. The patient actually required just about a 150, 1.5 diopters of cylinder in his intraocular lenses. But that gave him the adequate distant visual acuity also. And you can see that bilaterally implanted, this again ended up with a happy patient. So it's not just the spherical power of the patient, but the cylindrical power also has to be addressed, and not just in unilaterally, but I think it was a mistake to have been implanted with a uncorrected cylinder being left behind in the first eye, which we were able to address. We did offer laser vision correction to this patient in the second eye, but bilaterally implanted, the patient seemed to be quite happy and so chose not to do anything about his first eye. Now, what about if you have implanted a toric intraocular lens, but you find that the visual acuity requirements are not met with? As you can see over here, this was in the year 2019 when the Symphony was ruling the roost and the Synergy was just coming in. We're just getting initial experience with this. So the patient essentially ended up getting a toric Symphony, a significant amount of astigmatism that is there, and a 3.75 diopter Symphony toric lens was implanted. So we ended up achieving an excellent distant visual acuity because the astigmatism as well as sphere was taken care of. But obviously, a certain amount of near vision required a +1 diopter. So the patient was not quite satisfied, though he did understand that this was a compromise that he has already been talked to about, because that at that point of time, the other option was a multifocal intraocular lenses with a significant amount of dysphotopsia, and the patient chose to go for this. And when he came for this fellow eye operation in 2025, with almost a similar amount of astigmatism, now obviously we had the Synergy toric option now, 6 years later. So he implanted a Synergy toric and almost built upon a similar platform, essentially just differing in their optics. So what you see over here is that the patient's requirement as far as the distance and near was completely taken care of, including the intermediate vision, because here it was both toric lenses, but we had mixed and matched a Symphony toric and a Synergy toric, depending upon the requirements of the patients. Now, we come to a different scenario where in the one eye alone had undergone a LASIK treatment almost 28 years back. we primarily started doing laser vision correction way back in 1997. This was one of my initial patients. At that time, we had just a TMS2 topographer and used to take a pachymetry using a mm, our our ultrasound pachymetry. And basically, this patient underwent correction for a simple minus 3.25 diopters. Um, Hansetome assisted laser vision correction was done, achieved in one eye alone. The other eye did not have any refractive error. So it achieved an excellent outcome. For almost 25 years. They served the patient well. Of course, at some point of time, he would have gone ahead and required spectacle correction for his near vision, but then he was quite happy. And as you can see here, it's a fairly straightforward eye. And the most important indication for me to go ahead and offer an advanced technology intraocular lens or a multifocal or a trifocal lens for a patient who has already undergone a laser vision correction. Few years back, like most other surgeons, they used to consider prior history of laser vision correction as a strict contraindication. But now, if I find a patient who has undergone treatment for initial low myopia, like in this case, just about minus 3 diopters, achieved excellent, good, uncorrected visual acuity after the laser vision correction, not just as far as the quantity of vision is concerned, but also the quality of vision, where he or she enjoyed an excellent outcome and the treatment was well centered, that the topography was regular and had a minimal higher order aberrations. As you can see in this patient, it's a sea of green. This is just before the patient was subjected to the cataract surgery, and it's a very regular cornea that you come across. The treatment is well centered, and as far as the higher order aberrations is concerned, you can see that the higher order aberration in the cornea is extremely low, and the total higher order aberrations is also quite manageable. So essentially, I thought this is a patient who is a good patient as far as implanting an advanced technology intraocular lens is concerned. So essentially, the left eye had undergone a laser vision correction, right eye was a virgin eye. So you can see the what formula that we are using is a direct true K toric that's being TK toric that's being used. Especially if a prior laser vision correction is concerned, has been done, I always resort to TK, the total keratometry, because the relationship between the anterior cornea and the posterior cornea is somewhat compromised. And when it comes to a virgin eye, that if you have the total keratometry available, it's a added advantage, but it's not so much of a necessity. But basically what we used is a Barrett toric formula and a Barrett true K toric TK formula in the fellow eye, which had undergone laser vision correction. And this is just to show you the power of the lens and the axis of the implantation in the fellow eye. Essentially a small toricity that needed correction, but bilaterally implanted, you can see that the patient achieved a reasonably satisfactory visual outcome. Whenever you are dealing with a situation like this, you essentially tell the patient that you're going to try to achieve your best and not to promise them the moon, not total spectacle independence, nor do you always promise them excellent quality of vision. But if you are carefully choosing your patients, addressing them adequately, their preoperative concerns, then quite often you end up with a satisfactory outcome. What about a more challenging situation where it's a post-radial keratotomy patient, where obviously these are situations where I would stay away from implanting the continuous range of vision intraocular lenses or trifocal intraocular lenses, but do not go ahead and implant, especially in a well-done radial keratotomy of about 6 incisions or 8 incisions, where you have a 3 to 3.5 millimeter central optic zone, and the topography is reasonably regular. As you can see here, again, it's a reasonably central zone appears flattened, and what you see over here, again, I've used a Barrett true K TK formula in both these eyes. It's a post-RK scenario, and this patient essentially got a eye hands toric and bilaterally implanted. And you can see, though there was a requirement for plasma as far as near vision is concerned, both for intermediate and for distance, we ended up achieving a reasonably satisfactory outcome. Going on to a different scenario, what about toric intraocular lens post hyperopic classic? This again was hyperopic classic that was done almost 15 years back, And you can see over here what the kind of this is the topography just before the treatment was done. And so you can see that there's a central steepening over here, but again the treatment is well centered. And I would not hesitate to, this is the right eye and this is the left eye of the same patient. And as far as the treatment is well centered, and the patient's whatever visual requirement was adequately taken care of by spectacle correction, and it did not require contact lenses for his visual rehabilitation. These patients tend to do well with the toric correction. And essentially, you see in this patient that it was a significant cylinder that was needed. Not just cylinder, but the patient had also required a plus 32 diopter lens. So essentially, what we did was to go ahead and made a customized intraocular lens in this case, where we had a plus 32.5 with a 4 diopter correction in the cylinder. Such was the scenario in both the eyes. And you can see that we again ended up achieving a fairly decent outcome as far as the correction of the spherical error and the toricity was concerned. But obviously, this patient required spectacle correction as far as near vision is concerned. What about toric intraocular lenses in keratoconus situation? Obviously, it's extremely important that you center these cones either by doing a topo-guided PRK, unless it is already well centered, unless by doing a topo-guided PRK or by implanting intracorneal ring segments. As you can see over here, there's a significant astigmatism over here of almost -4 diopters. The 6/36 was also because of significant cataract, but you see that this cone is fairly decentered. So obviously what we do is, though the patient was almost 55 years old, subject the patient to a topo-guided PRK treatment. You can see that the best corrected visual acuity still remains 6/18 because of the cataract, but essentially the cylinder has come down quite significantly from -4 diopters to -1.5 diopters. Sometimes when you do a topo-guided PRK, the patient even ends up accepting more cylinder, but it's the regularization of the cornea which is most important. As you can see, it's a more regular bow tie compared to the preoperative picture now. This is what we achieve postoperatively. And when you look at the posterior float of the cornea, almost the entire cone is centralized in the central 3 millimeters. So obviously, this is a patient who do well with a toric intraocular lens. As you can see, it's a bimodal treatment that we have offered, where we have essentially steepened, flattened the area of the cone, and also steepened peripheral to the area of flatness, so that you have ended up a post TGPRK outcome like this. And this was the fellow eye of the patient. Similar principle was followed, where we ended up regularizing the cornea initially, then subsequently went ahead and implanted toric intraocular lenses bilaterally. Coming to another scenario, a piggyback toric intraocular lens for residual astigmatism. This was a patient, again, had a developmental cataract. I had done a phacoemulsification with the resume intraocular lens way back in 2003. At that point of time, it was this lens was quite popular. It's a zonal progressive lens. She went back and settled down in the US, but came back, and in the right eye, we did a YAG capsulotomy. In 2022, when she was a nice young lady of 32 or so, she wanted the residual astigmatism to be addressed. She had achieved an excellent visual outcome as far as near vision is concerned, but at that point of time, we did not have toric multifocal intraocular lenses. So we had left behind about 2.25 diopters. At that time, she was just about 10 years old, and about 2 diopters of cylinder bilaterally. She wanted something to be done for this. Obviously, the choice was to go ahead and address by laser vision correction. But quite to our surprise, her CBI, TBI, the bad D was all in the abnormal range, both in the right eye as well as in the left eye. She was quite insistent on the treatment. So essentially what we decided to do was to avoid laser vision correction, to go ahead and implant customized piggyback toric intraocular lenses in these cases. That's just the I'm not going into the capsular bag, but essentially creating space between in the sulcus. The spatula is going actually between the capsular bag and the pupillary margin. And this is a customized toric intraocular lens that's going just for correcting the 2.5 diopters of cylinder. It's a fairly large lens with closed loop haptics, a very stable lens, and it stays in the hydrophilic acrylic. and I've used these lenses in some instances and with a relatively good outcome. As you can see here, the toricity has been completely taken care of. Lots of the scenarios that we have, no, piggyback trifocal intraocular lens. Occasionally, when a patient has got a monofocal intraocular lens implanted in one eye, comes back for surgery in the other eye, requiring spectacle independence. When you implant a trifocal intraocular lens in the second eye, I find oftentimes the patient is quite satisfied. This was a patient who wanted something to be done for his fellow eye, which had undergone a monofocal intraocular lens. And so what we do here is to implant a piggyback trifocal intraocular lens. And this is again a hydrophilic intraocular lens available both from Indian companies as well as from Sulcoflex from Reina. We have experience with both these lenses. And you can see this again a trifocal piggyback intraocular lens. And it's a very simple procedure to implant these lenses. There is a possibility to correct toricity as well as spherical residual error if it is there. The final video of mine, which is a multifocal IOL exchange, this patient has actually received a multifocal intraocular lens implant, which was based upon the principles of positive playing around with positive and negative spherical aberration. Our initial experience had been quite good with these lenses, but this particular patient and some of my other patients were quite unhappy with the uncorrected visual acuity as well as the quality of vision, with a significant amount of astigmatism and residual error left behind. So this patient actually traveled from Africa, an Indian settled in Africa, who had got bilateral surgery done. 3 months later, after multiple communications over the email, he came back for an exchange of these lenses, just 42 years old, was not willing to give up his spectacle independence. So essentially what we decided to do after significant conversation was to go ahead and, that video, yeah, was to go ahead and exchange his multifocal intraocular lens, which is based upon a different principle, with a lens which a continuous range of vision intraocular lens. And as you can see over here, this was just 3 months after the primary surgery. This lens is slightly different. We are essentially explanting this lens, bringing it out of the capsular bag. And here I'm going to do implant the secondary lens. This is the lens which is going behind, so that this is essentially for this saving the posterior capsule. Significant amount of viscoelastic injected. Subsequently, because it's a four looped haptic lens that is there, I'm bisecting the lens completely. Otherwise, for explantation with these lenses, I will just cut it into 1/4 and then roll the lens out. But here we are basically completely bisecting the lens, and subsequently we are rotating this lens, explanting the lens out and in 2 segments. And this was done as 2 days later in the second eye also, so that bilaterally implanted, the patient ended up with a very satisfactory outcome. As you can see over here, just about 0.5 diopters of astigmatism behind. But so that this patient essentially was unhappy with a certain type of multifocal intraocular lens. But then after a certain significant amount of discussion, we replaced it with continuous range of vision lens, which operates on different principles, and ended up with an optimal visual outcome. Thank you so much for your kind attention.
Thank you very much, sir, for sharing that amazing case series. It was indeed precious pearls from your practice. Let us now dive into the moderated panel discussion, which would be led by Dr. Shika Basi, the Director of Neuro-Ophthalmology Services here at Sankar Nethralaya. Over to you, ma'am.
Thank you, Varsha. So after such beautiful talks, amazing talks, sir, Ramurthy sir, as usual, a very, very informative talk with so many clinical pearls. We'll move to the discussion, but before we move to the discussion, I would like to introduce. I'm very thankful for Dr. Varsha Bakebati, who is a consultant with oculoplasty department. She's an excellent oculoplasty surgeon, and she's also an excellent cataract surgeon. This combination, many of the oculoplasty surgeons, they give up on their cataract surgery, but she's an amazing surgeon. I've seen her operating at Arepuram, and thank you, Varsha, for agreeing to MC
Thank
to
you
be the
so much,
MC
ma'am. Thank
MC
you.
for our
It was
Cataract
my
update.
pleasure. Thank you.
So, with that, let's move to the discussions. I'm very thankful for the esteemed panel that we have, and thankful to the speakers too. So, let's begin with the first topic that was covered by Dr. Savio very beautifully. Uh, how he showed us how the multifocal lenses have evolved over the years, and he did show that this multifocality is achieved by dividing the light for different distances, like certain, and there are different technologies also coming up to give, other than this actual. I mean, like this is basically done in the diffractive lenses. He showed that certain IOLs they give more light for distance compared to the other. Certain IOLs they give more light for near, and there are newer technologies also. So what I'm saying is that there are lot of good options. Every lens has evolved with the concept of making a patient's life simple. So my question to the panel and all the speakers too is: are they seeing their practice moving towards giving the option of lifestyle IOLs to the patients? And if yes, how do they decide which technology they're going to use for which patient, depending on the hobbies and depending on the occupation of the patient? So I would like to start with Dr. Sudhir, and I'm sorry that as I had promised in my flyer that Dr. PP, Dr. Prerna Padmanabhan will be with us. Madam couldn't join the program because of some very urgent work she had to attend to. So I'm very sorry about PP ma'am not being here. So I'm sure Dr. RRS will be able to give us some ideas which are very similar to what Madam thinks, because he is trained directly under. So yeah, Dr. RRS, Dr. Sudhi.
Yeah, hi Shika. Yeah, I basically look at the profession and what their needs of the patient is. Based on that, we have to choose the IOLs, and basically those are like who are drivers. I generally try and give them an extended depth of focus lens because they are more comfortable because they're less photopic phenomena. So that is one thing which basically I ask all my patients: do you drive at night, or how about your activities at night? So if that is the one of the major questions which I basically decide on. And those who as far as the people who are more like housewives and who have more working with who does not drive, I think those are the people who are like they are good for panoptics or trifocal lenses. So this is one question which I makes it easy for me to handle. And patient, again, all these all depends on affordability. Many of them wants to have a good vision for all ranges, but unfortunately some of them are not affordable. Then we need to look into the other options, like go for extended monofocal lenses. They also give a very good vision, and if you club them with a mild monovision uh, thing, one eye at least to make them for the distance, and the other eye they also try and get a very good intermediate vision. But near vision they may not be that comfortable, but most of them they are able to handle their activities. So a mix of all, we have to look into it: affordability, their occupation. These are two things which I look into when they choose my IOLs.
Dr. Sudarshan, Dr. Kavita, would you do you ask something more than this?
Um, hi, Shika, and the all the talks were extremely. Actually, I learned a lot rather than I don't know if I'll be able to do justice by talking about. But my experience, please see, patients who nowadays we have a good profile of good number of patients who are quite well read about all these IOL options, and they come and ask us the lens types, and those patients are very easy. And doctors, I have seen a few doctors who were very clear. Like one was an OGIan and one was a dentist. They both have kind of a not very accurate near vision requirement, but they do need a extended depth. So they specifically said, I drive a little bit and all that. I don't mind having to wear reading glasses, but I need good vision to do unaided surgeries. So those patients, I offered EDOF VVT IOLs, and they were very happy. And actually, for me, they were even not requiring ads for reading. So of course, we can't oversay that profession is the first thing. So when they're very clear about what they need, it is very easy for us. We can offer them the options that then they can choose. But the patients who are the dangerous patients which we have is they'll say, in whatever is best, aap bataye, you tell us what is best for us. Those are kind of risky patients, because any issues that come, usually I have seen arising from those patients who kind of tell us to choose whatever we tell, whatever the negative things, they don't really listen. And when they end up having some issues, then they become very difficult to handle. So that is my experience in choosing patients.
Dr. Amla, Dr. Sudarshan, and Dr. Ira Verma have raised their hands. So yeah, Dr. Ira, I think she had raised a hand right in the beginning. Please introduce yourself and ask your question, Dr. Ira. Yes, Sudarshan, please.
Yeah, obviously, like it's an honor to be talking in front of all these three people. That's a different issue. The thing is, apart from the profession, I think nowadays reading is not about reading books or reading, having the things near you. So you don't need a 33 centimeter always. So most of them use near vision as a gadget kind of reading or a monitor type of reading, or you have an iPad. So even EDOF lenses that way can compensate reading even if it is like 45 centimeters or with a medium size font. So it's not always that you need to satisfy somebody with a trifocal lens and have them read at 25 or 30 centimeters. So that's not necessary that way. But then I have a query rather than a panelist opinion. So we are talking about mix and matching, like Dr. Ramurthy was telling about mix and matching. So I'm actually, I don't do too much of mix and matching. The only thing I try to do is try to make one eye little on the myopic side if it's an EDOF, so that they probably like get to have a much more nearer vision. I mean, sure near vision. And as you was telling, like when you're sure about one eye, what is the refractive thing and how the patient adapts, the other eye you can match the spherical equivalent or whatever accordingly. But is there a difference how the patients react if it's a diffractive and a non-diffractive mix and match? So do they complain? So because many times like somewhere else they would have done a diffractive and they want another lens here. So is it okay to go ahead with that, or it's always better to have a similar?
Would you like me to answer that?
Yes, sir.
Okay.
Because you are talking about mix and matches.
Yeah. No, as I said right in my first slide, 95% of my principle is also, to the extent possible, put the same type of lens, same type of, whether it's monofocal plus EDOF or trifocal in both eyes. And majority of the patients get that. And usually I give about a couple of weeks interval, between 1 to 2 weeks interval between the two eyes. Most importantly, to see what is the visual outcome, not just what the optometrist records there, but the comfort level of the patient in his or her day-to-day activities. Depending on that, I play around with the second eye. And most often, it's just playing around with the power of the lens is adequate. Just pumping up the power by about 0.5 diopters or bringing it down by 0.5 diopters. Sometimes, as you mentioned, we have patients who have had a monofocal lens done years back and now comes back and says that has a relative or a brother who has got a trifocal done, is spectacle independent. Asks, what about me? Can I get something done for my second eye? Or do I have to be? Then I say, it's less than optimal, but you can go ahead and get a trifocal lens. These patients who are looking for spectacle independence with unilateral implantation, I don't go for an EDOF because that's quite inadequate. They need full correction. So I go ahead and implant a trifocal lens, telling them this is not what I do normally. And then what I find practically, majority of these patients are quite happy and most of the activities are taken care of. There is an occasional patient I showed you in one of my last videos where the patient said that now I'm able to see well with my near vision. Why not about my other eye? Then of course you have this piggyback lens which you can slip in. But the requirement of that is not there. I think the as far as mixing and matching is concerned, once you are aligned with the patient's interests, it is up to the surgeon's imagination and as to what you put together. And quite often, I think the second eye operation is the best way of addressing the relative disparities that are creeped in from the first eye surgery.
Sir, in the same context, sorry to interrupt, Shika, do vision stimulators, like they talk about it, no? Do they kind of help us predict how the patient might experience, especially after one eye having some kind of problem?
I frankly won't be able to answer that. I mean, I've not really, experienced that. I don't have any information on that.
Dr. Savio, like, would you be able to, I mean, do you have an experience, like, how to guide
So we,
us?
yes. So what has happened is we have seen patients, and many of them, even after the need of lens or they complain or a trifocal lens, they have this typical waxy vision, and they say it's not sharp. So what we do is, especially if a patient already has a monofocal in one eye and asking for a premium lens in the other eye, we make it very clear that your contrast, your color is going to go down. And we take them, and in the monofocal eye, which they have done, we do a FACT chart and we say, see, your contrast currently with your monofocal lens is this, it's going to drop down by about 2 lines. Are you willing for this? So giving them a simulation is like basically how you do a dominance or a tolerance test before you go in for a monovision, and at least tell them it's going to be something like this, especially for the very demanding patients. Regarding the use of visual simulators where they actually put in lenses and they drop in, we don't do that. We just give direct for the contrast, and we show them on the screen that, okay, this is the brightness you have right now. Okay, it's going to come down by 30% if you can't plane monocularly, but if you see binocularly, yes, this is what you're going to do. These are done basically for the troublesome patients who have a monofocal in one eye, but otherwise we try to stick with the same lens in both the eyes. A monofocal with a EDOF still tolerable. Monofocal with trifocal, those are the patients you need to have a lot of chair time, get a special consent out, and then counsel them.
Yeah, that was my
What
question.
about one-eyed patients? In patients with one-eyed patients, what trifocals or
I have,
EDOFs?
Okay, sir, Ramoti sir will answer first, and then
no,
I'll take it on.
I had initial reluctance, but now I have implanted trifocal torics, depending on the patient's requirements and expectations. I have no hesitation as far as all other things are satisfied. I mean, right from the macula to the ocular surface, everything is good. Then why not?
Is that easier because they don't have any other eye to compare with, like vision?
In a way, yes. But then, as Savio mentioned, as to the difficult patients, my problem is I don't know who's going to be a difficult patient. The so-called A plus plus personalities, some of these politicians and industrialists and all, they never want to admit that they made a mistake, whether it be the choice of party or the choice of intraocular lens. They don't go around telling people. But that a simple-looking lady who is 60 years old, who we think will be least complaining, she comes and says, I see that light in the temple. There is a glow around that. Vision is not so good. And she goes around telling the whole colony that she's not so happy. She was better off. Really, if you guys have a magic mantra as to how to identify a difficult patient, I still have not got it right.
You can tell them probably you're saying God, hello. Like, so the thing is, like, one last question. Sorry, Shika. So like I had been, I saw a study in RO where they had compared, in comparison, all this contrast Dr. Savio was mentioning about the fact testing. They had done with EDOF of all the three companies, Wash and Luxmart and VVT and Pure C. And they felt even the pupil size also matters apart from the spherical aberration and the fact part. Does it matter in India? Because we are like generally like smaller pupil size compared to theirs.
I I would beg to disagree, Sudarshan. I mean, now that we have started looking at pupil sizes more often, I mean, we do find that there are patients who are ambient pupil size, that is in not in photopic conditions or scotopic conditions, in the range of about 4.5 millimeters in quite a significant population. Of course, there are extremely aged people who have significant meiosis. But then nowadays we are operating patients in their 50s and 60s. So definitely pupil size matters, and the amount of spherical aberration is directly proportional to the size of the pupil in the ambient light. So that's an area of concern.
I think
So what
Rajesh had a
happens?
question. Yeah, please, Dr. Savia.
Yes, ma'am. So what happens is when you're reading, by default, we have accommodation, we have convergence and meiosis also. But what is happening is we are all shifting towards backlit screens nowadays. And when we are reading, so what happens is there's so much dynamicity of the pupil. If you see at distance and near, we are noticing that even if you do the spherical aberrations with an eye trace, it's at 3 mm, 5, 4 mm, 5 mm, you will just see how it changes with each change in the diameter of the pupil. So spherical aberrations, I feel we are understanding it better now. If you see some of the older IOLs which you put were just spherical IOLs where patient had good intermediate vision, and then the aspheric lenses came and it dropped down. So we just didn't check intermediate vision at that time. So some maybe because of the pupil size at that time they gave good intermediate vision. So we are understanding that it's multifactorial, and definitely if you have a simple monofocal lens and a patient said I can read, definitely the pupil, the depth of focus is all into play. So we should keep that in mind also.
Thank you.
Dr. RPS, you had a question?
Yeah, thank you,
You had a
Shika.
comment?
Then this is my question to Ramoti sir. So you talked about the matching of the IOs. So my question is that now as the awareness of multifocal, trifocal EDOFs are increasing, when patient comes with one eye operated, the next time they may come and ask for a multifocal to be introduced in the other eye. So your opinion on this?
Oh, I think we just may talked about it in the sense that I do not, I mean, I do tell them that this is not an optimal solution. This is not what I normally do. I put a similar type of lens in both eyes. The patient really requests for it and understands that, we do go ahead and put a trifocal lens in the fellow eye with a monofocal lens. And quite often I find that, the visual requirements of the patient is taken care of. And they are relatively spectacle independent. And I do not hesitate to do that. And of course, an occasional very demanding patient, they find that the first eye is doing very well. We have this piggyback trifocals also, which can be slipped in. Actually, I've just used 3 of them, not very often. Most often with one eye trifocal also, these patients are reasonably.
So, Dr. Harsha Naik presented the clinical outcomes, comparative clinical outcomes. So, my question to Dr. Ramurthy is, how do you reconcile? He compared the results of Panoptics and Synergy. So, you think these study outcomes, they translate into the real world outcomes too? I mean, like in your practice, you agree with what he's presented?
No, I sort of very much agree with what he presented. We were involved in a global study on panoptics and did a study on synergy also. And both these lenses are very good. And frankly, I have little to choose. And, as he also mentioned in his presentation, most aspects there is hardly any statistically significant difference. And it was only some starburst where he was talking about contrast there, where there was a small degree of difference. But otherwise, I think in my practice, we both use these lenses quite often. And we do not, of course, and also even the Hoya geometric that Savio mentioned about, all these are excellent lenses. And I think they all, as far as the patient's requirements are concerned, they do take care of them quite adequately. I frankly don't find much of a difference between the performance of a synergy and a panoptics practically.
No. So in the clinical practice, do you think that synergy gives more dysphotopsia than panoptics? You agree on that in clinical practice?
No, not in my experience.
So you wouldn't hesitate advising synergy in somebody who needs good near vision, but at the same time, has some kind of work where the glare might be a problem.
No, see, whether my counseling does not change irrespective of the type of, whether it's Hoya or Alcon or J&J. if it is a diffractive multifocal, then it is going to split light. And you buy vision for all distances using the currency of contrast. So if somebody says, I want excellent quality of vision, no compromise in my quality of vision, but I want spectacle independence, I think diffractive multifocals is not going to work for them. But the POC that we have recently started using, we have done about a little more than 50 lenses of these lenses. I find that this is a reasonably good alternative. We have to still gather more experience with these lenses. It performs somewhat better than a symphony in the sense that it gives you reasonably good, the uncorrected near visual acuity once you hit emmetropia is about N8. And bilaterally implanted majority of these patients do not need spectacles. But this does not have any diffractive rings. And again, I think the VBT is a good choice. But VBT or a POC does not give you the quantity of vision that a trifocal can give as far as near vision is concerned. There is often, it's not N6 but N8. But I think both the Panoptix and Synergy is capable of giving you an N6 vision as far as even at a distance of 33 centimeters.
So now that you've touched on Pure C as well, and you say that you've used around 80 lenses of Pure C.
56 is what we have used so far.
56. What is your, I mean, like, how would you compare it to Vivity and iHands?
It's definitely better than iHands. It's one step ahead of iHands in the sense that, in iHands, whatever the company claims, there are hardly any patients of mine who do not require glasses for reading. No, that way there are some monofocal patients also who manage to read without glasses. That's because of various other optical phenomenon. But 1.25, 1.5, 1.75 is what most of my patients require. But with Pure C, what I find is more in the range of 0.75. And we are at present doing a prospective study. It's being done in 4 different centers. And bilaterally implanted, what we found is, even though it's N8 vision in one eye, bilaterally implanted, most of these patients are spectacally independent. So without the diffractive ring, so it gives you the quality of vision of a monofocal, but at the same time, it's a little compromise compared to a trifocal, but gives a fairly good vision as far as near vision is concerned. Very good for intermediate. Something similar to what we see with the Vivity.
So, do you think it's very comparable to Vivity?
Yes.
Even Pure C is a little yellow tinted lens, right? It's a violet blocking. It's not a blue blocking. It's a violet blocking.
Like the entire, the Synergy as well as the POC is violet blocking.
Violet blocking. So regarding Pure C, you just now said that it's the currency of contrast. It's giving something more. It's giving something little more than iHands. So where are we losing? What are we losing? They say its contrast is as good as iHands. So where are we losing?
The company doesn't. Yeah, go ahead.
Any studies that have looked into the contrast sensitivity or compared it with other monofocals? Because the company says that the contrast is, I mean, like, is it possible scientifically to have good intermediate vision or, to get good near vision without losing on the contrast?
No, the good thing about these lenses is that, there is no diffractive rings, there's no progressive refractive zones. It's essentially a change in the curvature of the lens, a gradual change in the curvature of the lens from the center to the periphery. The iHands has it on the anterior aspect, the POC has it on the posterior aspect. And it is this change in the curvature because of the spherical aberration adjustment that there is a certain amount of extended depth that you get. And this seems to work better with the POC, though the principles are somewhat similar, better with the POC than with the iHands. So you get a little more depth of vision with the POC. Tim Roberts and his group in Australia have conducted a study, and then they've studied this contrast sensitivity. And at least his results have shown that the POC, the contrast sensitivity is somewhat similar to what they get with the monofocal intraocular lenses. But this is initial days, and obviously we have to use it quite a lot before we really go on and dogmatically say that this is a significant step forward compared to the monofocal plus lenses that we already have.
So, if with Pure C, with the kind of review we are getting from you, if with Pure C we are going, you said you did show that in a few patients with micro monovision, you can give them spectacle freedom and an excellent quality of vision. You think that it could take the practice, it could shift our practice from monofocals to these extended range of lenses in future. You I mean, like, if there is nothing to lose and we get an extended range which can be with a little bit of micro monovision, we can give them a very good complete package. Are we moving towards that kind of ideal lens, or it's just a marketing thing?
No, I think the multifocal or a trifocal lens of the future is going to be a combination of factors. It is not just going to be diffractive rings or a curvature change. They're going to be playing around with the spherical aberration also, like the mini well lenses. They're going to be playing around with the distribution of light, like in the Hoya platform, the geometric lenses. It may be a combination of all these factors which will help. As far as your specific question about the POC is concerned, this was a lens which was not in the clinical study group, but in the prospective clinical study which we are conducting, which is being conducted in 4 centers across India, we were not allowed to do a mix and match. Basically, it had to be metropia in both the eyes. So when we aimed at that and implanted intraocular lenses, what we have found is that in an initial experience is that these patients read with each eye, they just read N8 or N10. But bilaterally implanted in about 12 patients where we have a 3 months follow-up, none of these patients have gone ahead and got glasses. So maybe this is a significant step forward.
Any comments from the panelists? Dr. Amla, are you there?
Yeah. I'm here. Hi. Yeah. Hello. Hi. I was wondering whether actually, like you said, all the multifocals, there's very little to choose between the various multifocals that we have nowadays. And the usual thing about the halos and distance driving and things like that is probably what most of us are asking for when we select a patient for a multifocal IOL. And I recently had a patient who worked in the film industry who complained a lot of the glare about the glare with the multifocal. Very keen on a multifocal, but not happy with the glare. But I've also had other people in the film industry who are fine with multifocals. And I was wondering if anybody has any opinion on multifocal IOLs, if under the glare of arc lights or whatever, whether there is a issue with specifically with multifocals, or was it just an individual difference? Because I've had people who were happy with multifocals also, and so, but there was one patient complaining a lot about the not being able to tolerate the halo, and there was nothing else otherwise unusual about the eye or the.
Any comments?
These individual differences always stump you. As I mentioned, you don't really, you think this will be a straightforward patient and would be happy, but they come back with a similar profile. Another patient is quite happy. So you really don't, whether it's a combination of factors, is the pupil size, is the amount of corneal aberrations, the psychology of the patient, all these factors come into play. And I think one very important factor was mentioned by Sudhir, and to me also, that is the primary question that I ask these patients. If night driving requirement is extremely important for them, that's one situation where I tend to keep away from trifocals. But otherwise, most often I do not hesitate. And of course, it's not that we don't have patients who have been unhappy with the quality of vision and who are complaining. But the problem is you can never exactly predict which patient is going to be unhappy.
So as a preferred practice, we don't use multifocals in uveitic eyes here. So probably a few of them which you have done in extended monofocal, or probably one or two EDOFs in uveitic eyes like Fuchs. So where like it is uveitic, but then like probably they behave less rigorously compared to others. So do any of you have done in uveitic eyes any of these multifocals?
Savi, you want to answer?
Yeah, I've done quite a few, and it's basically you have to see if it's not posterior uveitis, you're fine. Anterior uveitis, I still go ahead. Maybe I may have to use a ring to dilate the pupil if it is synechiae are there. But as long as at the end of surgery you have a quiet eye, I may start them before on steroids, keep them a longer time on the steroids. But no, I don't say if it's posterior or intermediate uveitis where I know there may be post-op CAB or something like that, then yes. But if it's just anterior iritis, I don't hesitate to give them the option at least of putting a trifocal IOL. Yes, I would tell them that eat off first, but if they desire to be glasses free, I do give them the option, and I have done cases also. But to avoid for the posterior uveitis or the cases which are very chronic, where you know they're going to have CME and they'll have problems. Sir, what is your opinion on that?
No, it's an absolute no-no if there is recent history of active uveitis, posterior or anterior uveitis, or the patient has been on steroid. But occasionally you come across a patient who hardly gives any history of pain, redness, etc. But you just see a posterior synechiae over there in one corner and an occasional pigment. There are these patients I do not hesitate. Especially if the patient hardly remembers that there has been, the usual signs and symptoms of uveitis. But obviously, if the patient has been under considerable treatment for uveitis, has had recurrent attacks, whether anterior or posterior, I think I would rather stay away from this. More because we are not able to predict what will be not that the trifocal is going to do any damage, but if postoperatively the patient starts getting recurrent attacks, macular edema and other problems concomitant with this, how we are going to deal with it? Why add one more variable to this patient?
I think, Sudarshan, I would like to ask you, since you've asked this question about multifocals, are you using iHands? Because iHands is kind of, I can see it's paving the way for some kind of multifocality in diseased eyes, right? So, are you using iHands?
Yeah,
No,
I do use iHands, but
don't
like,
call
you cannot call it
No,
multifocality.
diseased eyes.
iHands is not
In diseased
multifocal.
eyes. In
Like I mean, you can call it at the most extended monofocal, probably.
extended
No,
monofocal.
It's an enhanced monofocal, yeah.
Enhanced monofocal.
Sorry,
Enhanced
Okay.
monofocal.
enhanced
Yeah.
Monofocal.
Actually, I presented a paper on this on eye hands, no, in uveitic eyes.
Yeah,
In
enhanced monofocal.
both
Yeah,
Sudarshan, Parthu, and me, our cases we have presented. So there's no real
See,
issue with eye hands, I think, because
it's
that's
just a
perfectly okay.
monofocal which gives you a little bit
Yeah,
more
yeah.
of,
yeah.
So
So
that's
that
no
that was
intermediate.
actually that was
So,
precisely the question, because even if you want, if you consider using it, so I just had a query, because in fact the other way around, as Dr. Savio was mentioning, uh, ideally it is a no for a uveitic eye, but then given a choice, if it's a peripheral posterior uveitic condition, fine, rather than having a synechial anterior uveitic one, or a membrane around that, you would rather not use a multifocal lens or an extended depth of focus lens in a uveitic eye. Extended enhanced monofocal is fine with us. Like we've used quite a lot for the past 3-4 years in most of the patients, and like I don't find any great difference the way they react between uveitic and non-uveitic eyes.
Yes, even if the pupil size is a problem, I think
yeah.
they tolerate eye hands quite well. And
so,
not so much with vivity, but
Yeah.
so the multifocality given by playing with the asphericity is a little safe. Would you agree for diseased eyes?
yes.
Yes.
Uveitis
Yes.
for
Only thing
a
is,
lens like eye hands is
only
not, I don't think,
I
contraindication.
said, sir,
no, only thing is,
the
eye hands we don't
IOL.
consider it as a
Yeah,
multifocal lens, or
that's true.
you have a
No, but
monofocal.
they are paving a way. They are showing a way
No,
that
no,
wouldn't you say that Pure C, how they have achieved that? They've something again played with the asphericity, right? So
POC
it's
is
not
a
one step
no,
ahead of what iHands was giving.
POC
Uh,
is not a diffractive lens, I think
not
it's a refractive one. So it should be okay. It works on the same principle as eye hands. So I intend using it. I mean, if
no.
when it
No, the question is, I think, not about enhanced monofocal in diseased eyes. The question is about other things, about like visual quality, about contrast, and about other things when you have in a multifocal lens, which you don't want to add on or decrease contrast sensitivity and other things in a diseased eye. So you want, given a choice, you want to have a clear lens. That's first
Yeah.
choice. You don't want any tinted lenses. Second choice in diseased eyes. And third choice, you don't want to reduce the contrast or color vision in eyes which already have a diseased condition.
So
Yes.
what's your solution for that? You said three things, right? You said a clear lens.
Currently, probably I will not cross an enhanced monofocal for now.
No, I think a message from you coming for uveitic eyes, you're not saying any, as Dr. Ramurthy also said, you wouldn't consider a pure diffractive multifocal for these eyes.
Right away. I mean,
The
that's not
most
the
that you
situation.
can go is an enhanced monofocal. And I think the same goes for neurophthal patients or glaucoma patients or basic retina patients. For all diseased eyes, I think all of us agree with this, that we don't advocate even EDOF. That is the message. At least I don't put even EDOF in diseased eyes.
These monofocal plus lenses like iHands or Impress, they're basically, I mean, wherever you can put a monofocal lens, you can put these monofocal plus lenses also. Just get a
Yeah.
little extra, and I think it's definitely on. I mean, I would not hesitate to put a iHands in a uveitic eye simply because I think it functions like a monofocal lens.
And
And if
I've just to say that I've had patients with uveitis who have already had multifocal IOLs implanted, and have had uveitis later on. And as long as we've treated everything and the pupil is not a problem, they've never had any additional issues with the. I mean, they were comfortable with the multifocal earlier. They continue to be comfortable with multifocal later. I mean, so for the ones, I mean, who already had multifocals. Just
Yeah, I have a question to Dr. Ramurthy and Dr. Savio. Sir, the important thing is we have multiple platforms and multiple lenses. How do you choose on which platform, or do you, which is very, very difficult. So I go with what patient wants and give them the choice. But how do you choose, both of you?
You go first, Savio. It's a difficult question.
No, it's a very simple. One of the things is, yes, you are spoiled for choice. And in today's world, it's right that you have different options. So one first option is what the patient wants. Now, just last week, there was a patient who works as a waiter in the restaurant. It's a dimly lit restaurant. And he said, I need to read the menu. This is the actual case I'm talking. And I actually put geometric plus in both his eyes. Okay, now he's so happy because he can still read, and his manager, who actually has got another trifocal band, can't read the menu in the same restaurant. So it basically comes down to one, what does the patient want? That's one. Second thing is, I would say in India, we should think of cost. Cost is a factor, it is expensive. The Femtis lenses, which I even discussed, goes to about 2.5 lakh rupees because you have to club it with flax only per eye. So it is expensive and no lens is ideal. So cost will be my second factor. And the third is looking at the outcomes of the patient and the platforms. Now, if I've had good results with my Hoya lenses, I know upgrading to a Hoya Impress or upgrading to a Hoya Geometric, because the biometry is the same, everything is the same, I would rather stick with that. Same, I would say, with if I put a Technis lens and I'm happy with the response, I would very easily upgrade to a high-end POC or the other lenses with Synergy. So it depends on where your biometry becomes predictable and you're able to get consistent results. So for me, would be patient requirement would be number one. Second thing is the pricing. So what we do is we give options for you, looking at all the factors. This is number one. It may be the most expensive. Then option number two may be this, and option number three. You can choose, but we explain to you each and every option. So this is how we would approach Dr. Sudhir.
Thank you. Thank you. Yeah. Sir?
Sir, all to you, sir.
I think I would echo whatever Savio said. And, as far as torics are concerned, it's a no-brainer in the sense that any significant cylinder, we don't even look at the number. We look at what the biometry tells us. The Barrett toric calculator is our primary go-to formula. So the T2, T3, we definitely go for that. And especially for a trifocal or multifocal, we go ahead with go ahead and correct the cylinder always. And as far as my go-to lens nowadays has become a trifocal intraocular lens, unless the patient is contraindicated for that. That is, say, as you mentioned, the significant night driving requirement for me is a strict contraindication for trying out a trifocal intraocular lens. Otherwise, these are the lenses which I find that gives a excellent distance, near and intermediate visual acuity. I'm gaining some initial experience with Pure C, and I find that this gives a reasonably good quality vision. Not the quantity of vision is not the same, but maybe over time lenses like that would come to replace this conventional diffractive multifocal lenses. If a patient is focused on high quality vision, then I think the EDOF lenses would be the way to go. And then lower down the order, especially if it's price sensitive, then the monofocal plus lenses, which I think is one of the good things about is it's priced right. In the sense, most patients can afford to get those lenses in their eyes. Having said that, we need to mention about the Indian multifocal Indian toric lenses also, and we do use it significantly in our practice. Quite often, we find that my cost for the price in my center for a monofocal lens, imported monofocal aspheric single piece lens, is similar to what a Indian toric monofocal lens is. So in case the patient has two diopters of cylinder, rather than leaving with that patient behind with a uncorrected cylinder, and if the affordability is a criteria, we go ahead and use these lenses. So it's almost 50-50%. And my personal practice, almost 70% of the patients get torics trifocals. And I think going forward, we'll see that more and more uptake of these lenses. And it's just like our patients are happy to have choice as far as surgeons are concerned. We are happy to have choices as far as lenses are concerned. I think that's what promotes, more research and greater quality lenses coming forward. And I think in our own professional lifetime, I will see that this is evolving much more. And just like we don't operate without intraocular lenses now, I think there'll be a time when every lens that is put in has some kind of multifocality, and if torics, if there is a cylinder that needs to be addressed.
So what should be the minimum toric, cylindrical power beyond which you should go for toric in a multifocal?
No, Sudarshan, I mean, as I mentioned, this question is often asked, and but all we don't use the Barrett universal as a go-to formula. Go to, but it's a Barrett toric calculator. Every patient goes through a Barrett toric calculator, and if it shows a T2 or a T3 also, because against the rule astigmatism, even a 0.6 diopter sometimes, not sometimes, quite often you require a toric. But if it's with the rule astigmatism, even with a 0.8, you may not require a toric. So essentially, we go by what the calculator tells us. And in case affordability is not a criteria, even if it's a T2, I'll tell the patient to go for a toric, multi-toric trifocal. But sometimes with very small cylinders like a T2, if the patient is looking for a monofocal or a monofocal toric, I would not hesitate to just go ahead and place a monofocal. But especially for trifocals, I think taking care of even small cylinders is extremely important.
The residual should be less than 0.5. You should always see that your residual toricity is less than 0.5.
I think with that, we'll conclude the moderated discussion. Over to you, Varsha.
Thank you so much, everyone, for the wonderful, lively, interesting discussion. Now, I request Dr. Mona Kurana, Deputy Director of Glaucoma Services, Sankar Nethralaya, to summarize and give us the take-home message in closing remarks.
Good evening, everyone. We had an excellent discussion and wonderful talks, and I'll just summarize up everything for all the people attending. So, multifocal IOLs are an effective and satisfying option for achieving spectacle independence for, of course, vision purposes. This is possible only if it is accompanied by a thorough patient education, realistic expectations, and a meticulous preoperative evaluation. Of course, a flawless surgical technique and proper IOL selection. No size fits all. That's what we saw now. The solution is highly individualized and provides a happy patient and enhances vision and quality of life. The field, of course, is constantly evolving. So I just summarize a few points which everyone has discussed, starting with Dr. Savio. So he took us back in time to Dr. Ridley's time, and how IOL designs evolved from a patient who was happy despite a subluxated lens to how history again tends to repeat itself. From a sectoral lens to diffractive to apodization to combined, he clearly showed the optics and the multiple foci of the IOLs, as well as the importance of illustrating to the patient what they are expected to see, especially in the more demanding patients. And understanding the IOL design helps it match to the patient's needs in terms of lifestyle and hobbies. And you should be wary of large axial length and small axial length, as you may get biometry surprises in these cases. Dr. Harsha Naik gave us a detailed evidence-based comparison of two multifocal IOLs, Panoptics and Synergy, via non-inferiority RCT for 6 months, and showed that at 6 months there was no clinically significant difference in terms of vision, that is photopic and scotopic, and spectacle independence and contrast sensitivity, but the patient reported visual disturbance profile was slightly better with panoptics. Dr. Ramamurthy sir, he dived into his ocean of experience and pulled out many practical pearls. In 95% of the cases, according to him, both eyes, usually the same type of multifocal IOL can be implanted, but in the other 5%, you may play around by changing the power of the same type of IOLs to give a micromono vision, or you may mix and match in certain situations also. Challenging situations are post eyes after refractive correction. Those tips he gave for low myopic eyes are that eyes which had low myopia to begin with and good vision, and a regular cornea with low higher end higher order corneal aberrations do better, and a Barrett True-K TK formula is preferred. And patients with hyperopic classic, also the treatment must be well centered to provide a premium IOL in those eyes. Uh, in case of keratoconic eyes, torics need to be implanted, but prior to that, a topo-guided PRK or other methods to center the cone is preferable. And you can always piggyback lenses later if you have an unhappy patient, or even exchange the multifocal IOL. So we had an interactive panel discussion about lifestyle and IOL and whether it's a lifestyle IOL now and how to decide. Dr. Sudhir emphasized the occupation and affordability as well as the need for night driving to ask all these factors before deciding on the IOL. Surgeons may prefer EDOF lenses, and if you're lucky if you get patients who are very clear about what they want versus those who want us to choose what to implant in the eye. And the definition of reading has also now changed, with now everything becoming more iPad and mobile friendly. We may want to mix and match. Pupil size matters. Trifocals can be implanted in single-eyed patient. Deceased eyes need clear lenses which do not reduce contrast, and usually all it was a consensus that they do not go beyond eye hands. For the silver screen, the patients may have glare because of the bright lights they are exposed to, so be careful before implanting the multifocals. So what is important is what the patient wants. Second, cost. Third is what works good in your hands and what your biometry dictates. So, with that summary, I'd like to thank Dr. Shikha for organizing the Cataract Update and conducting an excellent panel discussion. The speakers, Dr. Ramamurthy, Dr. Harsha, Dr. Sabio, for sharing their vast experience, and the panel and the participants for an insightful discussion. Dr. Varsha for moderating so gracefully, and Johnson & Johnson, Alcon and Hoya for their support, and of course our excellent multimedia team. Thank you, everyone.
Thank you.
Thank you and good night. Thanks
Good
for your
night.
time.
Thank you.
Thank you all.
Thank you
Thank
very
you all.
everyone.
Thank
Thank you
you.
for this. Yes.
Thank you.
Thank you.
Thank you.
Thank you. Thank you. Bye. Good night.
Good night.